Thank you for joining us for the February edition of Coffee with Coker. As always, it is a privilege to have you join us. Immediately following today's presentation, we will have a question and answer period, so please feel free to submit your questions in the area provided in the GoToMeeting dashboard. The participant phone line will be muted for today's presentation, and the materials will be emailed to you after the conclusion of the session. As you exit the webinar, a brief survey will pop up, and we would greatly appreciate your feedback on this presentation as well as suggestions for future topics. Todd DeWeese, Vice President in Coker Group's Strategy and Operations Division, will be leading our presentation today. Please join me in welcoming Todd.
Good afternoon, everyone. Todd DeWeese speaking. Really excited about today's opportunity to share some insights regarding value-based population health management and where the market is headed over the next couple of years, where it is today. We've got a large and diverse crowd today. I'm excited to see that. And given that, as Savannah mentioned just a minute ago, we're going to keep it muted, and I will give plenty of time at the end for questions. If you're like me, you're probably wanting to get the questions out as quickly as possible because you're afraid you might not remember by the time you get to the end of the presentation. So feel free to go ahead and type in the questions as we go along, and Savannah will be happy to keep track of those, and we'll address those at the end. And then, of course, if in the event we do run out of time, I'll be happy to speak with anyone directly afterwards or respond via email. So let's go ahead and get started. One of the things I want to just speak as a preamble to this is that this is not a didactic overview of how to implement a population health management program. Really, what I would like to do today is to spend a little time to talk about the elements of payment reform and where its genesis began, obviously, which has been mostly with CMS, and how that is migrated into the private sector, and then ultimately how that is really impacting what's happening on the ground between provider organizations and payers and the creative things that are happening today. And none of this is because we do have, and I intended it to be this way, this is not an intention to be critical of anybody or any party, either on the provider or payer side. This is just what we're seeing in the marketplace and the kind of solutions that we're wanting to put forth, and obviously we'd love to get some feedback from the rest of the crowd today. So let's go ahead and get started. You can't really talk about, let's see here, make sure this thing is working. Okay. You cannot really talk about payment reform unless we take a couple minutes to talk about the Affordable Care Act, and I know everybody on this call has probably heard about it ad nauseum. The only thing I'm going to mention about it today is, since it is 6 years old, is that, as we all know, the law, and I think this is a little bit different spin on how others may be looking at it, is the law really just focused on three things, and that's really how can the expansion of coverage to those who didn't have access to health care could be achieved, and that's through premium subsidies and new taxes, expansion of coverage, and then freeing up money through taking money out of the traditional Medicare and Medicare Advantage programs. And as we all know, Medicare Advantage, we thought 4 years ago, was going to die on the vine, but for reasons we're going to talk about a little bit later, Medicare Advantage has become quite the hot topic these days, and appears to be a program that's here to stay. What the Affordable Care Act really didn't address, at least directly, was it looked at cost, unit cost, but it really didn't look at utilization intensity of services, the other side of the equation. And so once that was passed, then the legislators or the regulators then began to look at how they could create market-driven payment reform to couple with the changes that took place in the law. So consequently, as a result, the federal and state commercial payers have been using the changes that are associated with the law to actively engage with providers to engage in value-based contracting, accountable care initiatives, and population health initiatives. And then, of course, as we have seen and we've all read this year in particular, CMS has rolled out additional programs associated with the ACOs, the Next Generation program, and they've also expanded the Pioneer program. And then Medicare Advantage, as I mentioned earlier, as well as a number of selected managed Medicaid plans in states particularly where they have expanded Medicaid. They're really getting a lot more aggressive with or proactive with working with those providers that are really good at patient engagement, that can document well, who can identify gaps in care, and can help drive ratings and star ratings and risk adjustment factors for their population. These plans cannot survive without that, and they have to have their efficient provider partners in order to do that. And that's a key trend that's driving a lot of the value-based contracting. And then commercial payers, and I know we have some folks from the payer community on the call today, and I've spent time in the payer world as well. We have seen a definite uptick in two-way conversations, frankly, going on between providers and payers, and coming up with creative ways in developing accountable care-like organizations. Whether or not it is a certified accountable care organization really matter, but it is an opportunity to really start to drive more competition between providers like we saw 15, 20 years ago. These organizations for the providers, quite honestly, are frequently about market share gains as cuts in Medicare and other sources of revenue are coming down the pike. So just to reinforce a little bit more about what I was talking about in the previous slide, I'm not going to go through every one of these quotes, and this deck will be circulated later, so you'll be able to look at these in more detail. But these are from last year. You know, you have Sylvia Burwell. I'm sure you guys have seen this. Their goal is to move all Medicare payments to 90% by 2018. The private sector has followed suit. America's Health Insurance Plans has clearly come out and made a statement in supporting the changes that are going on in the public sector, and quite honestly, the Medicare payment mechanism, as it changes into alternative payment models starting this year, we will begin to see more definitive changes in the private sector as well. And so, and that speaks for itself in these selected payers that we've identified. We pulled out some quotes. Clearly, with Aetna, 125% increase in their value-based payment mechanisms. They're wanting to run 125% increase in their medical costs, or be run through value-based programs. 350 different value-based payment programs with the Blue Cross Blue Shield Association are in the market today, and they're looking to expand that even further. Cigna has a little bit different take on how they're creating accountable care programs. They've created these options that look a lot like accountable care, but it's more driven around the products that have been designed already in their portfolio. United Healthcare, they've come out and make it a clear statement that they're looking to make a 20% increase in their value-based payments. The numbers are a little bit smaller with United. A lot of that has to do with the law of large numbers. They already had a fairly significant number of value-based payments in their system, and because they are the largest payer in the United States today, the percentages are getting smaller as they increase. And then with WellPoint, what they're really focusing on is creating these population health communities and rolling their network PCPs into those programs in order to influence and drive the referral patterns that occur in those local communities. And then CMS, which we'll talk a little bit more about in a second with MACRA, as we all know, they're looking. This is essentially going to result in a 27% increase in value-based payments through the MACRA mechanism that was passed last year by Congress. So I feel like that for most of us, at least when I first heard MACRA last year, and MIPS, as you know, it's another whole vernacular that's out there. I wanted to at least, if you haven't already looked at this, for those who haven't taken the time, this actually comes from CMS. We've represented this a little bit to make it a little more clear. But MACRA was legislation, as you all know, it was passed last year that essentially did four things. Well, three things actually. That was a typo there. First thing is that, as we all know, the proverbial kicking the can down the street with the doc fix was finally repealed, and with that, they introduced additional payment mechanisms to reward value over volume. And then the way they did that was come up with the merit-based incentive payment systems, which is also known as MIPS. And really, all that is just the consolidation of three payment and quality programs that had already been in place, and they were all separate, of course. And we had providers who were participating in Medicare participating in a different level, so PQRS, the value-based payment modifier program, and then the EHR incentive program. And as we all know, which was recently announced by Andy Slavitt, who's now head of CMS, they're getting rid of the incentives as well. At least that's proposed, and it looks like they're going to probably remove that from the program. And then in addition to that, these bonus payments, which are rolled up under various APMs or alternative payment programs, which we'll talk about in a minute, are really the mechanisms that we will see over the next 4 years, 3 to 4 years, that Medicare will drive towards. So when you look at the Venn diagrams below, you can see where they've been, and what you can clearly see what their goals are is to basically squeeze traditional fee-for-service Medicare out of the system, with the exception of discrete providers that I would say are probably not good candidates, and that's another whole topic in another session to talk about which providers wouldn't be subject to the value-based payment programs that they're rolling out. But in essence, a full 90% will be linked to quality. That's their goal, at least by 2018. And then we can see a fairly significant increase in the APM program. So hopefully that gives everybody a little bit better idea. So when we look at under MIPS, what all these APMs mean, it's really 4 areas. We all know about the accountable care organizations. They've been in place for a few years now. The Medicare Shared Savings Programs, Track 1, 2, and 3, are underway, and as you know, we have over 400 Medicare ACOs today across the United States. The majority of the beneficiaries are really concentrated in Southern California, Florida, and the Northeast, and then we have pockets in Texas and some places in the Southeast, and then there's a lot of white space in between, but that's beginning to change. In fact, we're working with an organization that is consolidating a lot of rural providers and organizations to form Medicare shared savings programs starting this year. And so in the next 12 to 24 months, we're going to see a lot of white space fill in with new entrants into the MSSP program. The next generation ACO program, which we've heard a lot about, there are approximately 21 of those today, 21 today in 13 states. And that's really an extension of the Pioneer ACO program, and really it was designed to create incentives between the Medicare Shared Savings Program and the Pioneer ACO program, which is really more of a full risk model, the Pioneer was. And it also introduced more waivers for providers to be incentivized to get into it, and for those who wanted to take more risk and share in more of the savings and the upside potential under the next generation program. So 21 this year, and we fully expect to see more in the coming years as CMS begins to provide more incentives to participate in that. And then the bundle payment program, we all know very well. A lot of hospitals today are being directly impacted by that in the joint replacement program. There are approximately 800 hospitals today, PPS hospitals today, that are going to be participating in that in April. So whether or not folks are ready for value-based care, it's here. And then when you roll on down into advanced primary care models and other models, these are various models that are state-specific and in a continuation of existing programs to drive the patient-centered medical homes. So moving on, what does all this mean? We sat down and started thinking about, and this is really more from a provider's perspective, you know, what does all this mean in terms of various contracting models that that could impact us over the next couple of years as we begin to develop these population health programs that are going to have a value-based component with it, and how aggressive do we want to get? And let me just preface this by also saying that I don't know what region everyone is from or what market they're in. All of this is dependent upon very specific, you know, this is an aggregate, so various markets based on market power and market share and market penetration and managed care, all those have impacts and bearing on what this would look like specific to their market. But in general, on a national scale, I think this is a fairly accurate picture. The other thing I will point out here that that a lot of folks haven't really talked about much in the last couple of years, but we're beginning to see it a lot more, and you're seeing it more in the press too, is the employers, large self-funded employers who either have the means, if they're large enough, to work with forward-looking provider organizations who have built the infrastructures, particularly those who are already involved in this on the CMS side, to leverage and avail themselves of the same programs that are being offered to Medicare beneficiaries, and or they're actually aggregating themselves into these other private co-ops. You know, we've read some recently. I wish I could have highlighted the icon that was from the Wall Street Journal, I think 10 days ago. There's a group of large employers in the Northeast that account for about 4 million members that are going to be aggregating their data and essentially begin to start using that leverage to drive better negotiating power where their employees reside. But if you look at this, it's clear that in a discounted fee for service as we know it today is going to be down across the spectrum. Whether, you know, it's already diminishing today, and we'll see it diminish further. Some markets, again, let me just, for those who might be bristling or recoiling with that statement on the phone, there are markets that will see a less of an impact in this, but in general, we are seeing this trend. Value-based payments, with CMS, we've seen this will essentially be the full replacement to traditional fee-for-service, as I talked about earlier. And then, as typical with the commercial sector, we will begin to see the commercial plans drive more and more towards value-based payment programs, which is not necessarily, it does not necessarily have to be tied to an ACO or even an organized provider network. These could be value-based payments with individual provider groups or individual providers. That topic of conversation is coming up more and more. With shared savings and ACO programs, and ACO-like programs, CMS is essentially encouraging what I would say is track-free ACO, which, as you all know, is a two-sided MSSP program at a minimum. So in the next 3 to 4 years, we will see the early movers in the MSSP program either begin to move out into another model that's been created by Medicare or exit. And that doesn't necessarily mean no longer taking care of the Medicare beneficiaries, but perhaps move into more of a risk-based model. Well, I think we will also see the growth of commercial ACOs in this segment. It's still relatively small today. A lot of this has to do with the fact that providers are slower to adopt. I think with the payers, they are anxious and eager to drive these conversations with shared savings programs, but they're finding that a lot of providers are not necessarily equipped or ready to do that just quite yet, even in those instances where they have a Medicare ACO in place. But that will change. It's less than 10%, but we'll see that go up over the coming years. I think, again, large employers are really watching this, and they're beginning to see the results for Medicare, and they are wanting to get into the game. So I think for those organizations, those provider organizations that have large employers in their markets, I think this is an interesting time to begin to have those conversations, if not informally, about what you're doing in your market to drive quality. On the shared risk side, really for CMS, just map this to a pioneer or next generation ACO. We're going to see some increase in that in CMS, but it's not going to be as dramatic. And then on the commercial sector as well as direct employer, we'll see some increases in that, but today there's really not a whole lot of activity there. Full risk, this particular model, as we all know, is ingrained mostly in California, but we are seeing some of this in other markets as well. And really for CMS, we won't really see CMS push this beyond this year, but really it's in essence the bundle payment program for them. And we'll talk a little bit more about that. And then for global risk, I think today it's still being talked about. I think there are a lot of memories from the 90s about global risk, and quite frankly, commercial payers are wary about assigning full global capitation to even large integrated delivery systems. There are exceptions of the world that have proven and shown that they can manage this, but there's a lot more due diligence and caution in moving in that direction. We'll see some increases there, but certainly employers will be more interested in the shared savings programs. And then the episodic payment bundles, I think this is an area where everyone's going to be jumping into the game. Commercial payers won't be going into it quite as much. We have found, in my experience, this may change. So, I'm prognosticating here 4 years out, but we're finding a lot of commercial payers are having trouble administering episodic payment bundle programs, and the provider organizations, obviously, who are administering this are needing a ramp time as well. As we know, this involves complicated risk pool designs and payment mechanisms that go out to physicians as well as hospital savings retention as well. So we will see increases, just a little bit more caution there. And then I will say that global risk, though, for CMS, in essence, I've just, for convenience, I've included it in here as Medicare Advantage. I think we will see a lot more provider organizations seeking to work with CMS directly to take full risk from CMS through a licensed health plan that they may create themselves. And there's lots of opportunity there. So in essence, that's the overview of where we think this is headed as you think about the types of payment programs that are out there, the prevailing programs. So what does all this mean for our provider organization and thinking about what their portfolio? You have to really think about the risks of cannibalization to the current portfolio and what's the timing of this. This is a standard curve here. Those curves could be a lot steeper depending on whether or not it's a highly competitive market, or it could be a lot flatter and the intersection point much further out. So this is not in any event in any way designed to say that it's imminent, but what other point is to be made here is that we have found that clients where there is a threshold where, and it's typically around 40 to 55%, where their value-based reimbursement is a mix of the fee-for-service. Once that happens, if they're not equipped to address the responsibilities that go with managing that, reporting quality and driving efficiencies, they're really going to find themselves swimming upstream very quickly and in trouble. And so one of the things you want to think about before you get to that transition period is making sure that you've decided as an organization what is the appropriate reward for the value and risk that you're taking. That's important to really spell that out, not for that to be necessarily dictated to you. You need to make sure that, well, I'll just state it this way. Everything has a cost. So when these programs and infrastructures are being put in place, and even if you're running a Medicare MSSP, as you know, your costs are not being covered very well. So all costs really need to be taken into consideration. And I'm not suggesting cost shifting here, but financing of that of the enterprise that's going to be running your population health program, you really need to think about what's that going to cost today and what is the total cost of ownership of that over time, because that will be a very strong consideration. And obviously the programs that you put in place that are going to generate value and create savings need to pay for themselves eventually. And then this is something that's oftentimes forgotten in conversations. It's amazing how often it is the entire continuum of care. When we talk about population health, most people think about it in terms of primary care, preventive care, and all the things that happen before what goes on in the hospital. Well, I'm here to tell you that you really need to think about what's happening in your hospital, how the hospital partners are working in conjunction with the physician partners, getting those readmissions down, length of stays down. All that needs to be seamless and tied in very well. And then finally, which I see most often forgotten, and it really ends up being a snake in the woodpile, is post-acute care strategy. Whether it's hospice, skilled nursing, rehab, home health, a lot of these partnerships are 100+, and rationalizing that down to a sizable and workable referral network. If you are going to be a more strategic provider of care, taking on more risk, and being responsible for the ultimate outcome of the population, you need to have the right post-acute partners and being able to track their performance. Not doing that will end up costing the organization. So What are so I have another slide that's the opposite of this, which is what are payers or providers seeking and payer partners. But I'll start with what are payers seeking and provider partners. So I've taken some information that's from a national payer. It's public information, and we've based on our experience, kind of looked at what really this all means in terms of how to align your strategy as a provider to what the payers are thinking about in terms of their product strategy. And we're going to talk a little bit about product redesign as well. But as you can see, the patient from a product perspective is as a consumer today. So whether that consumer is inactive or active, that's going to really drive in what kind of programs they want to place those consumers in. And ultimately, network access will drive a lot of that as well. So unfortunately, for all of us who've been in managed care negotiations for many, many years, a lot of population health strategies, at the end of the day, will be talking about the good old-fashioned bread and butter of unit cost discussions and where all that needs to be. I would suggest that it's not a zero-sum game today, but it's more collaborative. And how can we work together to drive the right kind of solutions in the local market so the employers can stay in business and stay in those communities, because ultimately everybody wins. So from a national perspective, the providers who are working with, and again, this is a large national payer perspective, so there are different perspectives if it's a small local payer, but really the providers need to be growth oriented and when they're talking about population health and value-based contracting. They really need to work with their payer partner to talk about how are they going to drive business in their local market, whether it's a national plan that's for national that's rolled out nationally or local. The next thing that I would map to in a tiered network that a lot of payers are developing is transformative efficiency. So really, you need to start thinking about how can I create a competitive advantage in my marketplace over time, over a reasonable period of time, that satisfies the customer and we're all customers, whether it's a payer or provider customer. And then as you begin to get a narrower network and tie into closer integrated networks, and private labeling is what I would call the next local alignment, they're really going to be looking for tight physician integration and how well the physicians work together and keeping those referrals in network. And then ultimately, those high-performing networks are really going to be where the payers want to steer their members and consumers, because it's going to be maximum transparency, and those providers that can really show that they're always moving the needle and always raising the bar with the existing resources and programs they have in place today through care redesign and activation of the consumer jointly with them is going to be the winner of the day. Now, some people were wondering, well, why should folks ask for more discounts? Well, that's just a natural part of the discussion. I'm not suggesting that there will be better, and maybe there are already significant discounts in the marketplace. But generally speaking, we're seeing that the discount asks do get greater as the network gets smaller. So what are providers looking for in their payer partners? Well, you know, there is a place for the payer community, and quite honestly, I tell my provider clients that they need to have a multi-tiered strategy. You know, working with employers in the local community, partnering with the right payers of all types, and then really working hard to reach out and take ownership and responsibility for the population. But as payers, you know, these are all business-to-business models, and they are shifting. You know, it's like steering a battleship, if you will. But you know, if you look at on the left side of this screen, every one of the national payers have these basic functions in their organizations. It's a traditional value chain that's set up to serve large employers, whether it's product innovation or provider management. And so really the transformation that population health-minded provider organizations are looking at are not necessarily asking them to throw the baby out with the bathwater, but really change the face of how they look to the consumer as well. And so they really need the payer partners to be service providers. And this is what when we're representing some of our provider clients with payers, these are some of the things that we're talking about. What are they going to be doing as the service providers that are in their market? What kind of customer service do they have? What's the enrollment and fulfillment turnaround times? They need to move from being just actuaries and underwriters to financial managers. Consumers are being asked to take on more responsibility for their healthcare costs, and the deductibles are much higher than they used to be. There need to be tools that allow them to manage that more effectively, either through HSAs and other payment programs. And then obviously with transactions, that's claims and enrollment and fulfillment functions. Those need to have high accuracy rates, obviously, and high levels of reliability. And then really on the health services network optimizers, this is really something we're seeing a lot too, is that for those provider organizations that have advanced care delivery organizations that have their own care management functions delegated, they have utilization management delegated, they have claims delegated. They're really looking to work with the payers to help the consumers steer them to the right providers at the right place and at the right time. And that's really what this is all about. And then updating their systems and capabilities so that not only does the plan, but also working in conjunction with the provider partner, anticipating what those individualized needs are through consumer data and predictive analysis. So we've all heard about big data. It's out there. And health plans have as much information on consumers as anybody does. And that can be used, quite honestly, to really come up with a lot of nice tailored disease management programs that are more than your, I would say, your bread and butter care management programs and case management programs that you see today with a lot of payers, but really targeted towards engaging and activating members in the local markets based on their individual needs. So the next slide, in our experience, there are really three things that we've seen over the last 3 or 4 years, and in working with clients, what's really, what are the three common themes that are driving success for population health programs? And not surprisingly, it's all about the patient. And we have found that if they're focused on the patient and taking care of the patient, a lot of things will ultimately take care of themselves. But in addition to that, you need to have the right stewards and the right leadership in place who know how to take the appropriate levels of risk for the population that is served in that local market, and understanding what those plan designs are that are going to appropriately incentivize members to utilize the services that are available to them in the appropriate way. If that's not done, then you're not going to have the right connection, and it will fail over time. The other thing is it is a lot about data. If you don't have data to drive the engine of this, then you can't manage quality, and you can't understand where your gaps are. So that's obviously something that is ultimately very critical. And then really, some people are saying, well, improving margins, what's this all about? Well, really, it is about improving margins, because if it is done correctly, then high-performing providers will be rewarded. You've got to set those incentives the right way in your risk and funding pools if you do decide to go into higher levels of risk. It's absolutely important to ensure that those providers are appropriately incentivized, and that's another whole presentation to talk about what providers and which funding models need to be aligned. So, so as you think about the philosophy, what do you do just at a high level? What are the first steps? What's the first step you need to take? Now, I'm sure there are a lot of folks on the call who've already undertaken a population health program and already have a value-based program in place. So perhaps this is a little bit repetitive, but perhaps this also gives you a little bit of a gut check around, have I asked the right questions and am I thinking about this the right way, or do I need to course correct going forward given the changes that are going on in the marketplace? But when you think about the triple aim, which is an overused term, the way we look at it is there are three areas that are really ultimately going to drive what they call the triple aim, which is better experience, improve outcomes, and reduce costs. And we already talked about this. Payer simplification, streamlining internal processes, providers becoming more accountable for fee for value, and consumers becoming more engaged. With that in mind, an organization that's looking to develop a program, the first thing they need to do before they take any other steps, before they talk to any payers, before they need to start engaging employers, is start to do some research and understand what the local payer and product market dynamics are, because that's going to really drive the strategy where you need to be at the beginning and where you ultimately want to be. Determine service area demographics. That's extremely important. What is the health of your population? What is the supply of primary care physicians in your marketplace? Does your network need to invest in more primary care or advanced care professionals? What is the local health population health profile? There is a lot of variation across the country, and a commercial plan that has a $1,000 deductible in one market is very different from the same commercial plan design that's in another market that has a 50% less life expectancy rate. So all those really need to be taken into consideration as you're thinking about that. And then, as an organization, what is your readiness around taking risks? Do you want to just do shared savings, or do you want to just do do you want to be just a value-based participant? And then what kind of market and product alignment do you want to attach to? And then, obviously, as you move along the risk continuum, if you do want to take on that, then you are going to need to be prepared to be a delegated provider. And then begin to start talking to direct employers in the local marketplace, and also engaging and cultivating those local payer partnerships to see who can work with you in addressing those three previous areas. Those are the three things you really need to think about. And then the final thing is then you get to the next set of questions, and you take into consideration the what I call the foundational drivers that throughout the entire planning process need to be taken into consideration. But as still a part of your assessment, the next level questions you need to understand is then what will these impacts have on the service area? What is that optimal product delivery model? What is that path performance accountability? How deep will our organization want to go in taking risk? And then really, I'm amazed at how many some clients we've gone into didn't really think about what the cost of ownership of this initiative is, and what the cost will be to them, and what kind of cannibalization to existing portfolio of businesses would mean to them as they move existing business to a value-based system. You really need to think about this and what kind of impact that will be, and then plot your glide path accordingly. Then you get into the mode of designing, and what is going to then you can start talking about what are the those neat things like what is my consumer engagement strategy. Who are those progressive employers that are going to actually want to work with the plans that I've designed? And then the other thing that I would point out here is particularly important is if you haven't already gone too far down this road is as a entity that's taking on population health programs, try to develop those that you think that are going to cover 80% that are common to all or most payers. I've seen a lot of situations where they try to take these off and try to take them on as one-off, and then if you end up with 80-some-odd quality measures you're trying to administer for your stakeholders who are downstream from all these deals you've negotiated, you're really setting yourself for a huge headache. So to the extent that you can manage that down and negotiate with your payer partners to keep that into a manageable level, because it's keeping it simple, particularly on the front end, because you want to create the early wins that will sustain the momentum that keeps this program going on in the future, and it can be very successful. And so anyway, I will pause there, and I think we're about at the end of the time. I'm right at 1:47, so I think I was asked to leave at approximately 15 minutes left to talk, so I'm going to stop and we'll take questions. Are there any here? Let me see if I'm using this tool correctly. Looks like I've got a couple here. Could you provide a quick overview of the joint bundled payment program? Yeah, I talked a little bit about that earlier. It is on the CMS side. I'm assuming this is a CMS question. It's about 800 PPS hospitals, and I believe it's in about 67 MSAs. And that covers about 30% of the population in the United States. So this is going to have a major impact on a lot of providers across the country. It will begin on April 1, and I think it's going to be for 5 years. There will be eligibility for reconciliation after year 2 for Medicare for those savings that are generated. And there will be a pay performance program as well. I believe they're going to come up with 2 quality measures and a voluntary submission of patient-reported outcomes data associated with that. That's one question. See, CMS and AHIP, along with CQMC, just released common core measures for quality metrics in multiple areas 2 days ago. Many private payers are going along with the government to use the same measures. Yes, I did see that. I didn't have time to incorporate that into this slide deck, but that's a very good point. And more to come on that. I just don't have a lot to say yet because that's just hot off the press in the last 2 days, but a great point. And then someone's asking, what is beginning on April 1st? That is the joint replacement program by CMS. The next question is, why are provider organizations so interested in forming their own Medicare Advantage plans today? It's interesting because I remember sitting in a conference about 5 years ago, and all the so-called experts said that Medicare Advantage would be dead by now because of the Affordable Care Act. It's really been a fascinating transformation in the last 2 years. I guess people didn't realize that the pig and the python is the baby boomer generation that is moving, that's aging into Medicare, and a lot of the programs that CMS has put into place to really heighten the bar on the payers to drive quality through the STARS program is actually creating a superior experience for members in relation to traditional fee-for-service. So quite honestly, the benefits that are available, even with thinner margins today, it still can be shown that they can make money. And then with the risk adjustment program, even with the changes they made last year and the star rating program, there is a lot of opportunity. And what the payers have realized is that they got to have strong provider partners to make this successful. If they don't, then they can't be successful, and they're going to have to get out of business, get out of the Medicare Advantage business. And so providers who are, participants in these programs, they're getting some incentive payments, but I think the larger organizations that can take risk, they're seeing there's a lot more opportunity to generate margins off that business. So that's really the reason why today. And it's growing 2 to 5% every year. So it's the pot's getting bigger, and it'll continue to get bigger over the next 15 years because of the baby boomers. So it's here to stay, and it's growing. Let's see here. Do you expect more employer direct contracting? If so, what types of employers? Yes, I do. In fact, I'm actually, interestingly enough, for the first time working with providers. Although when I ran a clinically integrated network a number of years ago, we were doing direct contracting. But this seems to be a really big conversation nowadays. And for those employers that have high employee concentrations, like municipalities and state governments in geographies, they're really particularly interested in driving some of those discussions with those provider organizations that have the capability. And it's not that they're trying to drive the payers out of the picture, it's just kind of redefining what those relationships will be in order to maximize the opportunity for success. Let's see, on the physician side of the house, 2 questions. First, nationwide, what percentage of practices are you seeing taking on risk? What percentage of practices? At the individual practice level, I think that's really, it's really real. So if you're in Southern California or in the Southwest, a lot of these organizations are taking CAP, even CAP directly from a risk-bearing entity. They're used to operating in that market. In risk-bearing entities in other markets, they start out their physicians with discounted fee-for-service and add withholds and other incentives to transition them over time to eventually move to CAP. But the key is having the right panel size and the right mix of patients in order to make that successful. And then the second question was, what do you believe are the top 2 reasons why ambulatory providers are moving into population health? Ambulatory providers, I'm assuming that when we say ambulatory, we mean physicians. I'm going to make that assumption. Well, it's obvious. I mean, the market, whether or not you are voluntarily engaging in population health, you're actually doing it. A lot of times I ask the question when I'm working with a client, they say they're not really doing population health, and I ask them how much Medicare Advantage business they have, and they'll say, well, I have 10% or 5 or 25, and I say, well, you're already doing population health, you just don't know it. So hopefully that answers that question. In regard to physician compensation, what percentage are you seeing being allocated performance-related to value matrix? I'm not sure if I understand that question, but I think what I might do is scroll back to another slide that I actually skipped over because I wasn't sure if I was going to have enough time. Hopefully it's there. It must have been removed. But I'll make sure that it's in the deck. It actually plots out the maturity of population health to level of risk and the various payment programs that are aligned with those. I think that might address that question. And I'm sorry we didn't have time to include that in the presentation day, but I will put it in the slide deck. How much time do we have left here? About 5 minutes. I think we're also overwhelmed with all the reporting initiatives now that it's difficult to see how we will manage adding even more complexity to the lives of the primary care physicians in my practice. Doesn't anyone see how all this just increases dramatically the cost of business? There's no way it works. Let's see here. There's no way it works out to benefit physicians financially. Only the insurance companies will benefit. What makes this any different from the IPAs and PHOs of the 90s, all of which have failed after countless hours of work and great financial investment? Wow, there's a lot of questions in that one. I don't know if I have enough time to address all those. But I think that is a. I've been in the business for a long time too, and I've heard a lot of the same concerns, and I'm not saying they're not legitimate. I think there are ways to be successful in that. If it's a small practice that's a solo practitioner around a lot of competition, and that practice is not aligned with anyone or any organization, it's going to be a very difficult slog over the next 5 to 10 years. There is absolutely no doubt about it. If I were an office manager, I would be really worried too. It is a challenging time. I don't know in that respect. I don't know how else to address that question. There's a lot of premises behind some of those questions, but they're definitely legitimate concerns. Let's see here. I think those are all the questions. So I think that wraps it up. Savannah, I will hand it back over to you.
Thank you, Todd, for that presentation. If you have any additional questions, you can feel free to reach out to Todd directly, and he will reply to those questions you have. Again, the slides to this presentation will be emailed out to you. Thank you again for joining us. Have a wonderful day.